Could hypercapnia be neuroprotective?
Thank you so much for that, and I declare some conflict of interest, which are shown here. Carbon dioxide may well be very important because it can influence the cerebral blood flow, and then it could alleviate brain hypoxemia. And then the question is, of course, how relevant is brain hypoxia as a secondary injury mechanism? And I urge you all to look at this very nice study by Mipinder Sekon's team from Vancouver, where they monitored invasively cardiac arrest patients with brain oxygen monitoring, so PbO2 catheters. So this may be routine in your neurosurgical patients, but not so much in cardiac arrest patients. There are very few studies actually on this. The patients that I included were mainly patients with a hypoxic cardiac arrest, so probably had some degree of brain edema. They put in ICP monitoring, PbO2 monitoring, jugular bulb catheters, and took numerous blood samples. And then they looked at specific time points when the PbO2 measurement was low, when the brain oxygen was low, so probably then suffering from some kind of hypoxia. And then they looked at numerous biomarkers of brain injury. So this is a schematic presentation of what they actually done. So here you have the patient. You can see up there the jugular bulb catheter, and you can see that they took samples from there, and at the same time they took samples from the artery. So then by looking at the differences in the level of these biomarkers in the artery and in the jugular bulb, they were sort of being able to look at new release of biomarkers. So the instantaneous release from suffering brain tissue into the bloodstream, and then being able to be measured at the jugular bulb. From jugular bulb samples. So they then calculated the differences between these. So sorry, the pointer isn't working, so I'll have to explain it to you. But on the right-hand top side, you can see controls in gray, and then patients with a normal level of oxygen in the brain in red, and then the patients in green with hypoxia. And then below you can see the gradient of those two values. So basically what they were able to show that during these hypoxic episodes there was new release of these brain injury biomarkers, so suggesting some sort of ongoing injury. So if that's the case, what can we do about this? How can we alleviate this? One idea would be, of course, to increase the carbon dioxide, because carbon dioxide, as you will know, cerebral autoregulation. We have on the y-axis, we have cerebral blood flow, and on the x-axis, we have cerebral perfusion pressure, we have the oxygen, and we have the carbon dioxide. And as you will see in orange, PaCO2, so with an increase in the PaCO2, there will be an increase in cerebral blood flow. So perhaps this could be one mean to increase cerebral blood flow and alleviate brain hypoxia. And there are actually mainly some observational studies. Here's some of our data. On the left-hand side, you see on the x-axis carbon dioxide levels during the first 24 hours, and then on the z-axis, if you like, the oxygen, and on the y-axis, the observed good outcome rate at 12 months. And then the right-hand side, you see the same thing, but adjusted for baseline characteristics. And definitely there is a kind of intriguing signal that high carbon dioxide patients seem to do better compared to low carbon dioxide. And if you look at the group with the combination of low carbon dioxide and low oxygen, then that seems to be the group that does the worst in this observational study. And there are some other data showing kind of the same thing. Here's a very large Dutch registry data cardiac arrest patients. On the y-axis, you see the probability of death, and on the x-axis, the mean PaCO2 over the first 24 hours. And then you see a curve describing the association between these two, and the point of the lowest predicted mortality is actually around 6 kilopascals, so around 45 millimeters of mercury. So definitely the higher end of what we consider to be a normal carbon dioxide. So how about some animal data? Well, Giuseppe Ristagno's group, I was involved with writing the protocol, did this very elegant study looking at moderate hypercapnia in experimental cardiac arrest. So 14 pigs with ventricular fibrillation induced with an occlusion of the LAD. Long cardiac arrest, 12 minutes, followed mechanical chest compressions, and then in the animals with return of spontaneous circulation for 4 hours, ETCO2 targeted ventilation, comparing a sort of regular level to a higher carbon dioxide levels. And the PaCO2 values were definitely higher in the moderate hypercapnia group than in the normal capnia group. So with this moderate hypercapnia, you can see in blue the blood pressure, systolic blood pressure, mean arterial pressure, and diastolic pressure. There was a bit of differences. So higher pressures with moderate hypercapnia. Is that due to increased venous return or something similar? I don't know. The primary, we looked at injury in different areas of the brain, and the most important one in general would be the hippocampus. There was no difference there, but there was some difference in the frontal cortex. These are not so many animals, so of course it may be possible that this is due to chance, but nonetheless there was some signal there that moderate hypercapnia could influence brain injury in these animals. So pilot studies, we think about what's the end point in a pilot study. Well, it's a biomarker. And in most of these studies, NSE, so a marker of neuronal injury to the neuronal body as a consequence of, for example, cerebral edema is very commonly used. But also in some newer studies, the axonal biomarker neurofilament light has been used. So these are, of course, markers of brain injury, but they're, of course, not at all relevant for the patient in any way. But providing a perhaps mechanistic evidence that perhaps this is a therapy that has good properties. So this is the CCC trial conducted in Melbourne, Australia, published 6 years ago, compared a PaCO2 of 35 to 40 to one of 50 to 55 for 24 hours. So 180 patients were screened, 80 randomized, and all around 40 patients in each group were then analyzed. Primary endpoint being neuron-specific enolase. You see that on the left of this picture, and as you can see, the straight line, the black line without any, is the normal capnia group. And the other one, the stripe line, is the moderate hypercapnia group. So you see that the NSE levels over time are much, much higher in the normal capnia group than in the moderate hypercapnia group, suggesting quite actually a dramatic effect in neuron-specific enolase levels. Then with regards to S100B, not much of a difference. So based on our observational data, we decided the Coma Care trial, pilot study as well, a little bit different setting in a way that it was a factorial design. We studied 3 different interventions, but one intervention was high normal or low normal levels of carbon dioxide for the first 36 hours after ICU admission. Only patients with ventricular fibrillation due to a cardiac cause, delay to return of spontaneous circulation 10 to 45 minutes from the phone call. So we achieved good separation. Here you can see the PaCO2 values shown in kilopascals. quite close to the higher end and to the lower end. Well, how did we achieve this? Well, here you can see in the high normal PaCO2 group, tidal volumes around 5.4, frequency of 11, and in the lower group, slightly higher tidal volumes, a frequency of around 12 on average. Of course, there was a degree of variation, but not that dramatic differences in the ventilatory settings. We measured near-infrared spectroscopy. You can see also the targets, what it looked like at the bedside, and there on the right-hand side, the near-infrared spectroscopy monitor, which basically we collected this data, but kept the number from the clinician. So the clinician didn't know what the number was. So definitely targeting a higher carbon dioxide increases cerebral oxygenation based on NIRS, RSO2. This is statistically significant. I mean, is this difference dramatic or not? Hard to say, but it's definitely there. There's a difference. But no difference in the primary endpoint, which was a neuron-specific NLAs. So you can see the two groups there, both behaved in a very similar way. We also looked at neurofilament light, measured that post hoc. You can see on the left the lower target of neurofilament light levels, and on the right the higher target and their neurofilament light levels. So no statistically significant difference. Perhaps slightly higher levels with the higher target, but it's definitely not statistically significant. So where are we with this? Well, some of you may know that the TAME study has been conducted, has randomized 1,700 patients, 2 carbon dioxide targets as in the CCC trial, so 50 to 55, 6.6 to 7.3 kilopascals, or normocapnia 35 to 45, or 4.6 to 6 kilopascals. The study is very close to being published. It's been almost accepted, some minor changes, and it will be out there very, very soon for your interest. So what to do in clinical practice? I think for now, normocapnia targeting a PaCO2 of 4.5 to 6, using a lung protective approach with tidal volumes 6 to 8 is the reasonable option at the moment, until further evidence will guide us. So conclusion, moderate hypercapnia is definitely a very interesting concept. It would be very cheap and easy to apply. It appears to increase brain oxygenation measured with NIRS. Some data suggests benefit, some does not. The observational data suggests an interesting association, but it's very difficult to interpret whether that is really there or not. TAME study will be published soon, and until then, we just follow the guidelines. And with that, I conclude, and happy to take some questions.